Today, our lecture is on EENT imaging. EENT stands for ear, eye, nose, and throat imaging. Now, EENT imaging overlaps with neuroradiology, but it is its own entity and it is very different from neuroradiology. How come? We'll study that in our lecture. So, without further ado, our first topic is sinusitis and the role of imaging in it. Now, what is sinusitis? It is the inflammation of sinuses in the human skull. As you might recall, there are 4 sinuses in human skull. There is the frontal sinus that is above the nose in the frontal bone. Then there is the maxillary sinus that is in the maxillary bone below the nose. Then there is the ethmoid sinus that is above, lies a bit superior and posteriorly to the nose. Then we have the sphenoid sinus that lies posteriorly to the nose in the sphenoid bone. So there are a total of 4 sinuses: the frontal, maxillary, ethmoid, and sphenoid. Here is another look anteriorly, so you might remember it. So there is no need for imaging during sinusitis. The allergic sinusitis usually resolves spontaneously. Bacterial rhinosinusitis requires some medication and is diagnosed through physical exams. So the imaging only comes in sinusitis when we have certain complications and we want to evaluate them, or there is some kind of an impairment to the sinus drainage and there's accumulation of the secretions inside the sinuses, or there's a certain disease called paranasal sinus inflammatory disease if that disease starts to develop. Now, there's few indications as to when we need to have imaging done during sinusitis. That is when we have the sinusitis persisting for more than 4 weeks, or we have frequent and recurrent sinusitis episodes that are frequent but are apart about 4 weeks. Okay. As I earlier said, that imaging in sinusitis only happens when there are certain complications, and paranasal sinus inflammatory disease is one of them. Here you can see it's in CT scan of the sphenoid sinus. Now the sphenoid sinus is not clear. It is incongruous. Both sides are filled with hyperplastic mucoid membrane. Now we have another image, another CT scan. Here again, both the ethmoid sinus and the maxillary sinus is filled with hyperplastic mucoid change. Here another image, again it covers all of the frontal sinus. This covering of the frontal sinus by this hyperplastic mucoid changes is called pansinusitis or opacification. And the proper term for this type of thickening is inflammatory hyperplastic mucoperiosteal thickening. Now the word mucoperiosteal is very important because during this inflammation, not only the mucous membrane is involved, but also the periosteum of the bone is involved. So if disease of this disease goes on for a long time, the bone erosion might happen, and it might start to infiltrate into the other parts of the skull. Another characteristic during chronic sinusitis is the formation of mucus retention cyst. Now, mucus retention cyst can easily be identified from the hyperplastic mucoperiosteal thickening. How? Because it has a very specific dome-like structure, it has clear boundaries, and it has simple mucus covering. Here you can see on the left maxillary sinus where the long red arrow is, we can see a mucus retention cyst. Next, the air fluid level. Now the air fluid level is particularly important during the purulent sinusitis. Purulent sinusitis is when there is pus or pus-like discharge from the sinuses. Now, this CT scan was taken when the patient was in the supine position. He was lying down. When he was lying down, the maxillary sinus showed a cleared level here, a cleared level of the discharge, and this is the air, and this level tells us that there is some kind of fluid or discharge present in the sinus, and this is more frequently happens in the purulent sinusitis, which is usually due to the bacterial infection. There you go, the purulent sinusitis. Next, we have the upright occipitomental view radiograph, or simply as it's called, the Waters view. Now, this view is very, very important. First of all, it's a conventional radiograph. It's not a CT scan. When we have purulent sinusitis, we have to evaluate and examine how the treatment is going on. Now, we cannot do CT scan at each interval, but what we can do is perform the Waters view to evaluate how the treatment is going. Is the discharge going away? Is the discharge going down? What is happening to the patient? Every time, instead of the CT scan, we can perform this radiograph. This not only saves time, saves money, but it's also easier for the patient. It is done by placing both the chin and the nose of the patient on the radiograph. Next, we have the nasal polyp. As I mentioned earlier, that one of the indications for imaging during the sinusitis is when there's some kind of blockage to the sinus drainage. One of the ways that blockage can occur is due to a nasal polyp. Here is a CT scan of a nasal polyp with the red arrows describing it. Now, finding a polyp on a CT scan is difficult because it has the same density as the other tissue. So you need to have a very good grasp of anatomy if you need to find out the polyps. Here the polyps is not only blocking the flow of the sinuses, but is also making breathing difficult for the patient. So the nasal polyps are diagnosed with a physical exam, but the severity of it or the grading of it, and to find out how the treatment is going on, we can perform CT scans. Next is the tumor in the maxillary sinus. Okay, now one of the complications for which imaging is required in sinusitis is malignancy, and it is a very serious issue because a malignant entity will not only invade and infiltrate locally, it might even metastasize to the distal portions of the body. Here is an example. Now, there is a tumor in the maxillary sinus of the patient here, and it is invading and infiltrating both inside the nose, inside the ethmoid sinus, and maybe even the sphenoid sinus. So, another indication of imaging for in sinusitis is tumors or malignancies. Here is an example of how we can find out such malignancies. Here is an tumor. This is an MRI scan, and this is a tumor behind the orbit of the patient, and it is infiltrating backward posteriorly towards the sphenoid sinus. Now, if we perform a contrast-based axial T1 weighted MRI scan, we can find out here that how much it has invaded, how much it has infiltrated, and how much it has gone inside the skull. This helps us both in the staging and in the decision of how to treat this particular kind of cancer or tumor. Okay. Our next topic is neck lumps. Now, neck lumps are very, very important, and every doctor needs to have a good grasp of them. Mostly, neck lumps are divided into neck lumps or nodules from the thyroid, or there's some kind of lymphadenopathy where the lymph nodes are swollen. There's some kind of a cystic mass, or there's swelling of the parotid gland. Now, parotid gland is one of the major salivary gland in our body. So let's get on with it. For neck lumps of thyroid, the choice of imaging is usually ultrasonography. Why? Because it's accessible and it is the best way to differentiate a normal nodule, a benign nodule from a malignant one. So, when are the thyroid nodules or neck lumps are imaged? That's when there is some kind of thyroid enlargement that is goiter. When there is a palpable thyroid nodule, or when patient is at risk for the thyroid cancer, or when we have some suspicion of thyroiditis. Now, all of these come from the physical exam. So first the physical exam was performed, and then the relevant imaging or the modality of the imaging was advised. Here is an ultrasound image of the thyroid gland. Here we can see the common carotid artery, the trachea, and this is the thyroid gland, and these small isoechoic but still differentiated areas are the thyroid nodules. Now, they might be benign, they might be malignant, but usually thyroid nodules are benign. Here is another ultrasound image of a thyroid nodule. Here both its horizontal and vertical size is also taken. Now, as I said earlier, that most of thyroid nodules are benign, but there are some that might be metastatic or might be malignancies, such as papillary thyroid carcinoma or the follicular. Now, follicular thyroid carcinoma is quite evident on FNSC, but papillary carcinoma is usually preceded by the cervical lymphadenopathy. Why? Because first the infiltration of the lymph node occurs, then the papillary carcinoma of the thyroid occurs. Now, in order to investigate the nodules of thyroid origin, we perform an FNAC. FNAC stands for fine needle aspiration cytology. What we do is that we introduce a fine needle inside the nodule, aspirate some cells, maybe some tissue, and then investigate those tissues under the microscope. Here we have a thyroid nodule, and this is the fine needle that is piercing it for the cytology. Next we have the cystic masses in the neck lumps. Now, one of the most common cystic masses in EENT is the thyroglossal cyst. Here it is marked here with the red arrow beneath the hyoid bone. Now this CT scan shows the thyroglossal cyst. Thyroglossal cyst is usually benign and it is congenital, but it might pose a threat, so we do need to have an imaging of it. We do need to have an appreciation of it. The second image shows the same thyroglossal cyst, but this is an ultrasound. Next one is the parotid gland. Now, parotid gland is one of the salivary glands. There are three salivary glands in our body. We have the parotid gland, the submandibular gland, and the submaxillary gland. Now, the second image. Now, the parotid gland might undergo swelling due to inflammation. It might have a certain disease called pleomorphic adenoma of the parotid gland, which is usually benign, or it might have some kind of an autoimmune disease, such as Sjogren's disease. In Sjogren's syndrome, there is a swelling of the parotid gland along with the dryness of the eyes, and the lacrimal duct is also compromised. It's an autoimmune disease which affects the parotid gland. The first image actually displays the submandibular gland. This little shadow here is the calcification in the duct of the submandibular gland. And here we have the parotid glands. Both are the salivary glands. Here is the normal parotid gland, and this one here is an inflamed parotid gland. How we can tell? Because the tissue density is same. Though it is enlarged, the tissue density is the same. The margins are not irregular, so we can safely say that this parotid swelling is pleomorphic adenoma of the parotid gland. Next comes the cervical lymphadenopathy. Now, cervical lymphadenopathy is very, very important. Why? Because there are many types of lymphadenopathy. They can be reactive, The reactive is when the lymph nodes swell up due to some kind of a disease, some kind of bacterial or viral disease, or they become matted and joined together during the tuberculosis, or they become enlarged during malignancies. Now, one of the most common malignancies of the neck is the lymphoma. Hodgkin's and non-Hodgkin's lymphoma. Both are diagnosed through cervical lymph nodes. Here we have an axial CT scan which shows the cervical lymph nodes. Now these two cervical lymph nodes along with this one on the right side and this one on the left side are swollen. They're enlarged. They might be reactive, they might be tuberculous, they might be necrotic, or they might simply be of due to metastasis. So some kind of investigation has to be performed on the lymph nodes. Usually it's again the FNAC and then the biopsy where we examine the tissue. One of the examples of lymph nodes swelling is, like I said before, is malignancy or cancer. Here we have squamous cell carcinoma of the tongue, and because of this, on the right side of the patient, the lymph nodes are swollen with a clear necrotic center. So lymph nodes might have a white indicators for being swelled up, but one of the most common one is due to metastasis. Next, the CT PET scan. Okay. A PET scan is a positron emission tomography. In PET scan, what we do is that we introduce a radionuclide and then we measure the radiation emitting from it. In this particular PET scan, we have introduced special glucose to the body, the fluorodeoxyglucose or FDG. Now, how much the body is metabolizing that glucose tells us the metabolic activity of the body. Now, this axial section of the PET scan tells us that there is a lot of metabolic activity going around in these area, and that is not normal. So this might be some kind of malignant lesions. So PET scans are necessary if we cannot find the primary tumor or we need some kind of confirmation for the malignancy. Next, we have the radionuclide thyroid scanning. Now, radionuclide thyroid scanning again is like PET scanning, where a radionuclide, in this instant iodine 123, is introduced in the body, and that iodine is taken up by the thyroid gland. Now, how much thyroid gland takes up that iodine and metabolizes it tells us how much the thyroid gland is functioning. Now here the thyroid gland is functioning well. Here one lobe is functioning a little better than the other. Here there's not much metabolic activity is going on, and here it is disproportionate. So by analyzing the metabolic activity of a thyroid gland, we can identify the cold and hot nodules. The hot nodules are the one which are benign, where the normal take up of the iodine or hyper take up of iodine takes place, and cold nodules are the one which are malignant, where actually the malignancy takes place. So we can identify those malignant nodules through radionuclide thyroid scanning, which is also colloquially called simply thyroid scan. Next topic, we have the facial droop or the Bell's palsy. Now, Bell's palsy is one of the most common affliction of the cranial nerves. It involves the facial nerve or the cranial nerve number 7. Here is an MRI scan of the brain. And as you can see here, that facial nerve is inflamed, and this inflammation of the facial nerve causes the Bell's palsy. Bell's palsy causes the facial nerve, the facial muscles to droop because they are innervated by the facial nerve, along with other signs. Some of the sensory neural loss is also there. But what we find on imaging is that that facial nerve is inflamed. Next is the dysphagia and sore throat. Now, for dysphagia simply means inability to swallow, or sore throat means that there's some kind of inflammation or infection going on in the pharyngeal area. Sore throat usually does not require imaging. Dysphagia, on the other hand, does require imaging. Now, how it is imaged? It is imaged by what is called a dynamic swallowing study. Now, what happens is that the patient drinks barium. Now, barium is a radioactive element, and that radioactivity is then captured onto radiographic films. Now, this is the patient's esophagus, and here is how this is the patient's peristaltic movement, and the barium is moving down the esophagus, but it is accumulating here. Now, this might be a neurogenic problem, or it might be a physical one where there might be a stricture here. Whatever the cause, we can find it out through the dynamic swallowing study. Now, these little fibrillar areas are of particular importance. This happens when there is some kind of problem, some kind of neurogenic problem in the patient where the epiglottis does not functions properly, and the barium splashes around and is aspirated in the lungs. So when that happens, we get a picture of something like that, not of something this smooth, but like this, irregular and fibrillar. Now, another way where the barium swallow can be halted is by the chronic hypertonicity of a particular muscle called the cricopharyngeus muscle. Now, this muscle presses against the esophagus and causes a temporary stenosis. Now, this stenosis, which is these arrows here, might cause the dysphagia or the inability to swallow, and this can be diagnosed only through imaging. Next, we have the Zenker's diverticulum. Zenker's diverticulum is a posterior pouch towards the vertebral column through the esophagus. Now, it is of particular importance because there might be some kind of contamination going on there, or there might not be, but it has to be investigated, it has to be examined, and appropriate treatment has to be proceeded. Here we have the Zenker's diverticulum. Now, this is an anterior AP view, anterior posterior view. If we look at a lateral view, this is the hypopharynx or the normal esophagus. This is trachea, and there is the little pouch that is called the Zenker's diverticulum. Now, during the swallowing, when the patient has drunk the barium, some of it might remain in that Zenker's diverticulum, which is actually a pouch. So that's how we can find out through its location and its retention of barium that the patient has Zenker's diverticulum. Okay. Now what is an esophagram? Now, when the patient drinks barium, all sorts of stuff can happen. The normal study will show a normal peristaltic movement like a gulp. But here you can see it that is not happening. There are multiple indentations inside the esophagus, and these indentations are due to strictures. Strictures are narrowing inside any lumen. Any structure that has a lumen, when it gets narrowed, we call it a stricture. So these strictures are actually causing the barium to not flow downward equally in a normal peristaltic movement. Now, this can be due to congenital malformation, this can be due to some pathology, or it can be due to, and most often, due to a squamous cell carcinoma of the esophagus. So, a barium swallow is a very good indicator and a confirmatory test of a esophageal cancer. Here, both the benign strictures can both be benign and malignant. Further studies are required to differentiate them. Okay, now this is an axial CT scan. It's a CT scan slice. Now, sometimes dysphagia can be due to peritonsillar abscess. Now, tonsils are what are found around the lateral wall of the pharynx. So, and any abscess there will hinder the swallowing motion of the patient. So, that abscess has to be drained. This little area here, which is different, this density is different from the other tissue, shows that there is some kind of either fluid, it can be sterile, it can be bacterial, infective, but there is some fluid here, which is usually peritonsillar abscess, and this here is the pharynx leading to the trachea and the esophagus. Okay, next problem is what we have, the visual problems. Now, visual problems are not usually imaged. Radiology rarely has anything to do with visual problems. Most of the visual problems or the eye diseases are diagnosed through physical exam, symptomology, and looking through the retina of the patient, which is called fundoscopy. But there are few instances where imaging might be required. One of the two instances are when there's some kind of mass in the orbits, or there's some kind of problem with the optic, both the optic chiasm and the optic nerve. Now, the problems with the optic nerve will be covered in the neurology section. Here, we will only study the problems with the orbits. Here, one of the common malignancies of retina is a retinal melanoma, where melanin containing cells metastasize or convert into a cancer. This little area here is a retinal melanoma. Now, this patient might present with blindness or some kind of focal problem, or maybe the fundus is clear. So, when all other tests are run down and a definitive diagnosis is not made, only then the radio imaging is performed. Here, through radio imaging, we can confirm that the patient has some kind of retinal malignancy, and if we perform FNAC or biopsy of this lesion and mass, we might find out that it is a retinal melanoma. Next, the MRI of brains and orbits. Okay. Now, as I said that in EENT, we only study masses in the orbit. Now, around the eye, there are various muscles. And these muscles, sometimes along with the fat pad inside the orbit, might give us a condition that is called exophthalmos. Now, exophthalmos happens during the Graves' disease. Graves' disease is a disease where thyroid is compromised, and exophthalmos, or the protruding of the eyeballs anteriorly, is one of its symptoms. Here we can see that left medial rectus is more prominent. This only happens in the exophthalmos during the Graves' disease. This does not happen elsewhere. Now we have another category that is called pseudotumors. Sometimes there are masses which look like tumor but actually are not. Here example of the right lateral rectus. Now this right rectus is both hypertrophied and it looks like it's a mass but it's not. So it's an example of a pseudotumor. Next, one of the problems in EENT are the hearing problems or the cholesteatomas. Cholesteatomas are highly destructive, invasive cancers. They start inside the middle ear and then expand outward. They cause bone erosion, they cause infiltration of both the bone, tissue, brain, vasculature, nervous plexus, nuclei, everything. It's a highly destructive and infiltrating disease. And because of this, we can see it here. As if you just compare the both sides, this side is totally eroded, and this is because of a cholesteatoma. And because of this, the patient is having hearing problem, because like I said, it starts from the internal auditory canals or the middle ear. So the patient suffers from the hearing loss. Another way hearing losses can be imaged is through a particular cancer which is called the schwannoma of the cranial nerve number 8, that is the vestibulocochlear nerve. Now here you can see that this nerve is both inflamed, and because of this inflammation the patient is experiencing sensory neural hearing loss. Now this is a very common scenario and can only be diagnosed through imaging. Now we can examine the patient that there might be unilateral hearing loss, but the exact confirmation of the diagnosis only comes through imaging. Another example of it is the mass in the left internal auditory canal. Now this Left internal auditory canal can have mass of any origin. It can be a metastatic mass, it can be a growth, it can be an inflammation, it can be an edema. Whatever it is, this mass is causing the patient to experience sensory neural loss, and this needs further examination. The further examination usually relies up to the attending physician. Next, we have the vertigo and tinnitus. In vertigo means that, in simple terms, dizziness. And tinnitus is the medical term of constant ringing sound in the ears. One of the most common cause of both vertigo, that is the dizziness where the patient experiences the world is collapsing and rotating around him, and tinnitus where the patient experiences a ringing sound in his or her ears, is by the compression of the internal auditory canals. Now, that compression usually comes from outside, and one of the major culprit is a large jugular bulb. Here, the jugular bulb on the left side is normal, but here on the right side, it's both expanded outwards and superiorly toward cranially, and this puts pressure on the internal auditory canal and the cranial nerve number 8, which may cause the patient to experience both vertigo and tinnitus because the nerve is compressed. Next, we have facial trauma and the temporomandibular joint, or simply TMJ. Now, facial trauma is a very, very complex topic. Now, to sum it up, facial trauma usually involves all the bones which lies anteriorly to the skull, which includes the nasal bone, the maxillary bone, the mandibular bone, the frontal bone, the zygomatic bone, and the ethmoid bone. Here this is a CT scan of a patient where the left orbit is collapsed. The lower level of the orbit is collapsed and its contents are spilling into the maxillary sinus. You can also appreciate here the frontal sinus is also having its air inside the orbits of the patient. Here we have another MRI. This MRI is T2 weighted. We can experience that this is the condyle of the TMJ. This is the musculature and this is the dislocation of the joint. Now this dislocation of the joint is causing both the mandible to not function properly, and it is usually due to a blunt trauma or some kind of pathology at the joint, which might involve the synovial joint. Now, facial trauma usually involves two very specific fractures. The first fracture is the nasoethmoid frontal fracture, or the zygomatico-maxillary complex fracture. Now, these both fractures are very complex, takes a lot of multiplanar approach for reconstruction, and they can be easily appreciated on the water's view. Here we have an example of the lateral side of the skull where the nasal bone is fractured. And this here is the water's view. The water's view, we can appreciate that the maxillary sinus on the left side is clear, but on the left side there's a clear air fluid level. This indicates that there is, because of the trauma, there is blood inside the skull, and this requires further investigation in the form of either the CT scan or the MRI, because the patient is experiencing hemorrhaging somewhere inside the skull. Now, one of the newer and the latest trends in imaging is a volume render display, or more commonly called a 3D view. Here it is. Now, what happens in a CT scan, that in this example, the skull is appreciated all around in a 360 view. The X-ray is happening all around the skull, and all of this X-ray projection is producing a specific view, and all of that absorption and transmission of X-ray can be composed into a 3D structure. Now, this can only happen in one of the newer CT scans, not in the older ones. So it's a relatively newer technology, but it gives both the doctor a very clear picture of where the fracture lies, and it also eases up the patient as to where his problem is and how to tackle it and how to make a better judgment about of his or her treatment. Next one, we have the carotid artery disease. Now, the carotid artery disease is the leading cause of stroke in humans. Why? Because the carotid artery supplies through its internal and the external branch the brain. And when it is compromised, brain undergoes ischemic changes, and those ischemic changes can result in either in a TIA, the transient ischemic attack, or an ischemic stroke. Now, that's why the appreciation and the examination of the carotid artery is very important. The carotid artery is usually examined through a Doppler ultrasound. Here is the Doppler ultrasound of the right internal carotid artery, as you can see here. And its lumen is very narrow. Because the lumen is very narrow, the pressure inside it are extremely high. Now, this second Doppler is of the right common carotid artery, from which the internal carotid artery bifurcates. Now, it has a proper lumen and velocities are not that high. Because of this, we can deduce that the internal carotid artery is either stenosed, or there is some mass that is pressing it, or there is some kind of atherosclerotic plaque inside it which is causing it to have a narrow lumen or stenosis. Now, this particular stenosis is hemodynamically significant or stable because we can appreciate the blood pressures in both the arteries. Next is the carotid artery disease with the maximal intensity projection. Now, this is a maximal intensity projection of common carotid artery at its point of bifurcation. This is the common carotid artery, and this is the external and the internal carotid artery. At its bifurcation, with this windowing option, we can see that there is some atherosclerotic plaque, and that plaque is causing both the stenosis and the narrowing which is causing reduced blood flow in both the branches of the carotid artery. Here is the CT scan of the same, but it's an axial of the proximal internal carotid artery, and it also shows these atherosclerotic plaques around its lumen. Next, we have carotid body tumor. Now, stenosis cannot only happen because of some kind of plaque, either atherosclerotic or an thrombotic. It can also be because of a tumor, and that tumor can press and compress the carotid artery, which causes a reduced pressure of the blood flow to the brain, resulting into a stroke. This MRI actually tells us where the tumor lies. This is the common carotid artery. Now, instead of bifurcating, there's a mass here which is hindering the flow of blood. That's all. Thank you for watching scardia.com.